So CO2 removal, or Co2R, it's really an up-and-coming therapy. There's so much that we don't know about it. We focused very heavily on the two main indications, hypercapnic ARDS and attempting to bring down tidal ventilation to improve and enhance lung protective ventilation. And we also focused on acute exacerbations of COPD. So that was our trial, which I'm really pleased with. It was a little smaller than anticipated because we were nearing the 3/4 mark at the onset of COVID, so we had to really shut the trial down, unfortunately. But we were looking for time to removal of NIV by starting CO2 removal, and we found that there was a clear advantage to starting CO2 removal. We had a significant reduction in NIV use, and although that may not sound like such a great thing, from the patient perspective it's hugely important, because lack of tolerance of NIV, the duration of NIV, the discomfort associated with NIV is really important to our patients. The next part of work that we need to do and analyse from the study is all of the work of breathing data, looking at the NIV alone, CO2 removal alone, and the combination, and that'll hopefully come out in the next couple of months. So, not yet. This is very much in the acute exacerbation phase. Whether the technology can evolve just like home renal dialysis has, where patients can dialyse themselves every day, whether that will ultimately prove to be a beneficial therapy to patients, or indeed implantable devices with an external membrane lung, much like an external VAD for patients, whether that will ultimately be a therapy, I think there's a lot more work that needs to be done on the technology and then thinking about that approach, but it's one for the future. Yeah, I think at this stage it's very much a niche method. I think the evidence is not there yet. There's a lot of discussion about the amount of size of the device, the amount of blood flowing through the device, the patient selection. We can show that there are certain physiological benefits, but that's not the same as hard outcome benefits for patients. So I think for both ARDS and for COPD, it's an evolving approach. There's certainly a learning curve for centres that do this sort of approach to CO2 removal in these conditions. And so it's not something just to pick up and start running with, but it's definitely something that we need to do a lot more research on.